If you're a healthcare professional interested in the treatment of leg spider veins by microsclerotherapy, this webinar is for you. I'm joined by leading experts in the United Kingdom, board members of the British Association of Sclerotherapy. And we have a very full agenda. Please be sure to check out the links in the description below and do check the website regularly for updates and resources. So, who'd like to start off by discussing how they select patients for microsclerotherapy? From my point of view, I think a clinical examination is sufficient. I think if you take an accurate, detailed history, if you stand the patient up and look for signs of chronic venous insufficiency and varicose veins, and if you have strict inclusion and exclusion criteria, you don't really need to resort to duplex ultrasound scan. What do you think, Zola? Do you think that we need to do a duplex scan in all patients, or do you think we can use duplex selectively?
Okay, so do I think we need one? No, I think what you're saying makes sense. Do I duplex everyone? I will almost certainly do a limited duplex on everyone I see. And I think we'll just talk about some of this later, but I think if you have availability of it, it is a great adjunct. And so from my perspective, I will look at a patient, I will examine them, I'll make sure they don't have obvious varicosities, but even in the person with just telangiectasia on an aspect of the leg or thigh with nothing bulging around, just because I have access to it, I will put a high resolution probe across that area and just sort of get an impression of what's coming towards it.
So, Emma, how do you select patients for microsclerotherapy in your clinic? Because to give us a bit of background, you run principally an aesthetic clinic, don't you, Emma?
Correct. So yes, we do have a low threshold. So if there's any thought process that they may need a scan, we will have a referral pathway, and we do have access to people who can scan for us. But obviously, if we think they need a scan, then we're not considering them for microsclerotherapy. They have to do things the other way around. So we're dealing with purely really cosmetic vessels, this sort of super tiny ones. And certainly in the criteria when they book, we do have a little bit of a tick box exercise for our new clients to just go through a sort of very short medical questionnaire and a description of the vessels that they want to have treated. That if we think there's any possibility that it may be something that we can't treat, we would then have a conversation with them or invite them in for that initial consultation. But we would always do a consultation first anyway. So, and it's kind of as soon as we eyeball them, like you say, once they've stood up for 5 minutes, if there's anything that is suggesting any underlying pathology, then we will send them up the referral pathway.
I think I'm looking at it. Zola has a different practice compared to yours, Emma. Zola has a phlebology practice where he's seeing a full range of vein conditions, and he also treats telangiectasia by microsclerotherapy. You've got principally an aesthetic practice, and you also treat cosmetic spider veins on the legs. So I'm curious to know, Emma, if you were to have somebody inquire about their leg spider veins, how many do you think you would say yes and treat them based on a history examination and inclusion and exclusion criteria? And how many would you have to enter into that pathway for duplex scan? Rough percentages. I haven't given you much advance notice to dig out the data, but off the top of your head, what's your sense?
So most of our clients, sort of just our demographic, is that most of our clients are sort of naturally in their 30s, 40s. So straight away, we're probably going to be looking more at cosmetic at that stage. But there definitely are patients that have underlying pathology that are contacting us. And I'd say that we are doing a lot of screening before those patients even get into clinic. So easily, I'd say, of the inquiries that we're having, we're easily straight away with even just a photo, being able to say we can't treat these without a referral pathway. Easily 50% we're sort of referring onwards.
Oh, that's interesting. I'm surprised. I would think that would be less than that, but that's interesting.
Yeah.
Okay. I would say that for the majority of people, you could select people by history examination and possibly a continuous wave Doppler. Richard, can I bring you in? You must attend more microsclerotherapy training courses than anybody else in the United Kingdom. What's your sense about how to how to include people for microsclerotherapy?
Um, it's clear that there are many patients that turn up to courses who have a high likelihood that they have got some underlying venous disease. I mean, it's one of the key take-home messages that we always put across is that you've got to be pretty certain to exclude any underlying venous hypertension before you treat spider veins where possible. And if and it happens on occasion where if people um, are told that, but they're adamant they want their veins treated, I think it just has to be documented very clearly that a discussion has been had with the patient that there are signs of underlying venous disease that you've advised gets treated. And the likelihood is that treating of spider veins may or may not be successful, and there's a very high likelihood that they will develop more if they don't address the underlying cause. It's a bit of a it's always a bit of a disappointment for patients who thought they were coming for what is a relatively inexpensive procedure, being told that they may have to go and get their larger veins treated for perhaps 10 times the cost of what it was going to cost them to treat their small veins. So I think clinicians' practices do vary. And I think that the publics can have a slight misconception. I think that varicose veins are a disease of the elderly, and they're clearly they're not anymore. There are some quite young people who do have truncal vein issues, even though the spider veins are their main concern.
Mm, that's very interesting, isn't it? And Richard, what's your sense of being able to identify those people who can undergo microsclerotherapy safely and effectively based on history and examination?
There are clearly some contraindications to sclerotherapy, but many of those are the sorts of conditions that the people that are seeking sclerotherapy are perhaps unlikely to. The aesthetics of their legs are going to be the least of their worries. They generally tend to be relatively fit and well, mobile, younger adults, although some of them are a little bit older.
Okay, good. I think we've covered that. I mean, my prejudice is that if you take a very detailed and thorough history, if you examine people carefully and you resort to continuous wave Doppler in selected cases, you can identify those people who can go on and have successful microsclerotherapy without having a duplex scan. Would anybody disagree with that approach?
I think it's fair to say that there are plenty of patients that fall into that criteria.
I wouldn't disagree with anything that's been said, but I think it's a case of the more information you have for a patient, the better you can counsel them. And I can think of one specific patient who I was I was pointing out to him that he did have significant reflux, but his only concern were his thread veins. He's gone on to have his thread veins alone treated. And actually, we've had probably about 4 sessions so far. And it's actually surprised me how well he has done so far. But on the converse, it's a case of, at least I know if he recurs or fails early or gets early thread veins back or there's a problem, he was well counseled on the concerns that you actually have underlying feeding veins running towards these reticular veins.
Yeah, I mean, I tell you that I'm confused because here's the thing, and I'm going to have to talk to Ron Bush about this. If you can cure a leg ulcer, C6, with local treatment with sclerotherapy, because he's shown this with terminal interruption of reflux source, TERS, why can't you treat C1 disease locally? Why do you have to treat the truncal reflux? I think there's a paradox there which I don't fully understand. And although the leading lights say you must eliminate all truncal reflux before you treat C1 disease, I'm not convinced, particularly in the light of what Ron Bush can achieve for C6 disease or C5 disease. I'll have to talk to him about that. And I know he's coming to the British Association of Sclerotherapists annual meeting, so I'll have to ask him about that. I think there are some people who definitely have chronic venous disease. They have spider veins around the ankle. They have corona phlebectatica. Clearly, you're not going to treat that by microsclerotherapy, but I'm not convinced about the need for duplex ultrasound scan. It's a bit it's a bit of a heresy to say that, but there it is. I'll put that out there for people to discuss and see what comes up. So we've talked about it. Who gets a duplex ultrasound? Well, we can be selective. You can have certain pathways. You can decide if they've got symptoms based on the history. You can see if they've got signs, and you can refer them for duplex ultrasound. What I'm not convinced about is, does a policy of duplex ultrasound scan and treating proximal reflux, does that improve the outcome of microsclerotherapy? Is there the literature there to support that? Do you know, Zola? Do you know, Richard? Emma? Do you know if that's the case, that there's literature there that supports you definitely get better results if you treat proximal reflux?
Feel that when you're looking for something, you're probably going to find something. And I think that with a lot of my patients, if there's any indication that there may be underlying pathology, but when you become quite experienced, sometimes with patients, you might give them realistic expectations, but you might say, well, we can take the approach that we can try to improve this as microsclerotherapy, but it may not work in this instance because there may be some underlying pathology, but financially that's not a journey that you can go on. So that's definitely an approach that I would start off with a lot of my patients. So then I think that would reflect on the evidence, because I think it would be a very difficult thing to evidence.
Yes, it's a difficult trial to do. Nobody's going to fund that trial.
I think
it's a difficult one to
It's
organize.
a classic example of some eminence-based practice. There's just enough people say it, and everybody believes them. And we don't have any evidence to the contrary.
Exactly. Well, we don't have any evidence to support it, really. Do we? Do we have strong evidence to support that rationale? I don't know. I feel a bit exposed saying that. Maybe there is, but I'm not sure. And Zola, we who have access to ultrasound by our side and have it there on, waiting with a probe, is that sloppy thinking on our part? Are we not engaging our intellect and just saying, well, I've got the ultrasound here anyway, let's just slap on the ultrasound, find a feeder vein and inject it?
I said before, I think the more information you have, the better advice you can give. I will place the ultrasound around the area of concern for a couple of things, just to make sure there's nothing truncal in proximity that's coming towards it that's refluxing. But also, and I'm sure we'll speak about this later, you can actually see sometimes reticular veins that run in to the area that actually aren't obviously visible just by looking at the skin. From my point of view, that then helps me future plan exactly what I'm going to do with this patient, because I'm not just going to address the telangiectasia. There's something that I'm going to do before that.
Okay, so I think we've discussed that. Difficult one, isn't it? Different practice. One of the things that was very interesting, and I did a poll on LinkedIn, is what should we talk about in the consent process? And of particular interest, I was thinking about death and stroke and TIA. Zola, do you mention death and stroke when you talk about microsclerotherapy or sclerotherapy in general?
Well, certainly from the point of view of there was a time when I didn't, but this conversation was actually had at previous meetings some years ago, and it sort of opened my eyes and raised my eyebrows. And certainly from the point of view of it is something that I have now switched to. I do certainly talk about stroke. I talk about TIA. I talk about death. I do try and put it into context. Touch wood, I've not seen one, but certainly it's a case of I know of colleagues who have had TIAs, strokes from just liquid injection into telangiectatic reticular veins. So certainly it's something that, although I would not reticent, although it wasn't something that I'd thought of before, it is something that actually it is on my consent form and it is discussed now with patients. But it's discussed from the point of view of you need to be aware of the worst possible consequences, and this just happens to be one, but it is extremely rare.
And that was stroke after liquid sclerotherapy, was it, Zola?
Yeah, I mean, certainly it's a case of I've heard from at a meeting of a senior colleague who actually had a TIA stroke. So it was certainly a protracted, it was beyond TIA, but it was a protracted neurological event after liquid sclerotherapy.
Did it recover fully, or was the person left with permanent?
No, the person didn't have a permanent disability. But certainly from the point of view of it was beyond the 24-hour TIA.
So it was by definition a stroke, but there was no permanent disability.
Damage, yeah.
Okay, well, that's reassuring. Emma, have you ever had anybody with a TIA or stroke after microsclerotherapy?
No, I haven't. And I think that part of informed consent is given a real balanced explanation of the potential risks. So with that type of thing, I would mention at the end of the informed consent that there's lots of theoretical things that theoretically could go wrong. And some of them could be quite nasty. But these are things that I'm not worried about happening. And I might give a little list of them as a like softer sort of umbrella, but I would be very careful about over analyzing them with the patient, because I feel like they are very theoretical, and you'll always have that one patient in the industry that between expert peers you've discussed. And whilst obviously we have to help a patient to understand if they're undergoing any procedure, be it for medical reasons or aesthetic reasons, it comes with risks. And that is the bottom line. As an aesthetic procedure, that there are risks, and for the purpose of aesthetics, they don't have to do the procedure. If it's medical, they've got those extra additional benefits that they're doing it for medical reasons to improve their medical well-being. But I think that in informed consent is also careful, definitely for microsclerotherapy, that while we might touch on those things, we help the patient to understand that the likelihood of them happening is pretty much very, very, very rare and unusual, and we're not expecting to see anything like that.
No, it's difficult, isn't it? I mean, it's difficult when you've got somebody who tells you they've got some spider veins on the legs, and then you start saying, well, you could have this treatment, but you might die.
Yeah.
Or you might have a stroke. It's very uncomfortable for me to say that. Richard, you'll know the stats. Has anybody ever died after microsclerotherapy?
Not that I'm. Yes, there has been, not in this country that I'm aware of, but I think it was after receiving Polidocanol, but that was because of a cardiac event related to the properties of Polidocanol. And that was one of the reasons why the French agency came down very hard on the doctors in France and told them they should not be using, we'll come on to this later, but not be using lower strength Sclerosants as foam, because it's an off-label indication. But the neurological adverse events with liquid sclerotherapy are very rare, which means from a pharmaceutical point of view, that's less than 1 in 10,000 administrations of the drug. So it could be one in many hundreds of thousands, but that's as low down as the categories go in pharmaceutical terms.
But that's interesting you say that, Rich. When you say neurological events, are you including migraine?
Yeah, migraine is uncommon, so that's up to 1 in 100 times of administering liquid sclerotherapy.
And
So
visual
it is.
disturbance?
So visual disturbances and scotomas are also uncommon. So they are again between 1 in 1,000, 1 in 100 administrations.
That's interesting because my impression is that it's more common than that, and I do warn patients regularly for microsclerotherapy that they might get some visual disturbance. And I do that because they might worry that they're having a stroke.
Hmm.
And I have seen a TIA after microsclerotherapy, which was very frightening for the patient and for me. But it didn't last very long. It only lasted a few minutes. So I do warn people about headaches, visual disturbance, and possible sensations down one side of their body. What about you, Zola? Do you mention visual disturbance and headaches and death and
Yes.
stroke?
Well, I
You do.
mentioned death, stroke. I certainly mentioned visual disturbances. I even specifically asked people about migraine. It's surprising. I've had 2 people who have had a migraine a migraine event post foam, and when the post microsclerotherapy, and then when you're talking to them, both of them sort of said, "Oh yes, a similar thing happened to me the first time you injected, but I didn't mention it then." And it was sort of a case of it. And despite the fact that sort of migraine and aura is something that I specifically ask, but it's specifically on my tick box form that I ask everyone, it's surprising that people don't volunteer it when asked. Regarding the part about death, I always do. It's putting stuff into proportion, but it's a case of I have to tell you this, but actually your risk of death is greater from walking out of my office now and getting hit by a truck crossing the road potentially than it is from the microsclerotherapy. So, I mean, it's a case of it's information that I feel. And as far as I'm aware, the GMC tries to imply that you have to tell the patients. But on the flip side, you have to put it in proportion, and you have to make the patient aware of exactly what scale of risk they're looking at. And certainly, life is a risk, full stop. Everything you do has a risk, no matter what. So it's just trying to put it in proportion in a delicate way. But yes, I do mention it.
Yeah, I think it's very difficult. I mean, obviously, the law on consent has changed recently, hasn't it? It used to be that you could tell patients what a reasonable body of doctors thought was appropriate. But now it's what a reasonable person having that treatment expects to know about it. I think it's almost impossible to consent people in the way that we're expected to legally, but there we are. And here's another interesting thing, and it's a little bit tied to consent, not so much for microsclerotherapy, but if you go to 10 different vein specialists with the same condition, you may get 10 different treatments. How can that be when they've all been consented thoroughly? Surely there should be only one outcome. I mean, for example, if you go to specialist A, you're more likely to have superglue for your veins. If you go to specialist B, you're more likely to have endovenous laser for your veins. If you go to specialist C, you might have ultrasound-guided foam sclerotherapy for your veins. How can that be if we're all consenting the same or as the patient would want to be consented? I don't know. It's difficult. That's a rhetorical question. Right. Difficult one, consent, but we all agree that we think death. I put this on LinkedIn, and here's the poll. What should we tell our patients about sclerotherapy? I don't want to unnecessarily frighten my patients, but I want them to know all the risks. And what would you routinely tell people? Well, just over half said they would mention death, stroke, and TIA, but that means 48% wouldn't. And some would only do so for foam. Some people said it depends, but they didn't tell me what it depends on. So I found that a little alarming, but interesting, because obviously this is a select group of people who are interested in veins, I would suspect. What sclerosant do you use, Emma?
So we only use liquid in clinic. We are very much of the opinion that if we need to start considering foam, those patients are possibly needing to go up the referral pathway. And that's probably a good indication for us where we would want to be scanning those patients. So I think that's sort of fairly safe to say, we're coming at from this end with these sort of more aesthetic vessels. And whilst we can do foam sclerotherapy, certainly for me, I think when we start coming more towards foam sclerotherapy, then you've kind of got that crossover where those patients may need sort of other kind of investigative things before we can make a plan for them.
Do you use Polidocanol or STS?
Both. So Toxi, Sclero, yeah, and the Fibrovein. But obviously at the minute, I think we're going to discuss this. There's been some problems with supply. So just going to say at the minute, it's very much what we can order.
Right. If you had a preference for one or the other, what would it be?
Do you have any preference? Just what's appropriate for the vessel and the patient? Yeah.
Okay. So you would use both, right? What about you, Zola? What do you use for microsclerotherapy?
I ended up flipping and then flipping again. I used to use STS. I then, and as we'll discuss in a bit, switched to Polidocanol because of the supply issues. I, however, then started diluting down the Polidocanol and thought, well, if I'm diluting down the Polidocanol to a lower strength, because sometimes less is more, then I might as well just flip back to STS and just dilute down the stronger stuff to the strengths that I was using before for many, many years. So actually, I'm now back to using STS of a range from 0.1, 0.2, and just dilute it down from 1% or dilute it down from whatever I have. And thanks to your little app, it doesn't matter what strength I pull off the shelf, it will tell me how to dilute it to whatever strength I need.
Great. So what do you order?
Just 1% STS.
1% STS and you dilute it down.
And I dilute it down. So I just have 3%. In the clinic, I have 3% and 1% on the shelf. That'll cover me for all foam strengths that I need for treating varicose veins. And I dilute down the 1% to the 0.1 or 0.2, depending on what I feel I need.
Okay. And we'll put a link in the description for the app so that people can dilute down from those strengths. Richard, what are you cringing when you hear what we're doing with these solutions?
Not cringing. Just it's worth just mentioning that diluting a proprietary strength drug is an off-label use. It's not uncommon in medicine at all. Anyway, I mean it happens often. It's something that when I was a clinician, doctors famously weren't very good at doing dilutions to work out the concentrations. The only people who were good at it were anaesthetists because they used to do it frequently anyway. But as long as you're certain the concentration is that you're diluting to is what you're wanting to achieve, and with a your app or with guidance that can be done. The important thing is that if it is diluted, that it needs to be used straight away, not stored, because it dilutes the buffers and preservatives in the solution as well. When or if something went wrong, then there might be questions asked because there are proprietary concentrations of solutions at the right strengths, which is why they're provided like that. So done carefully, it can be done.
Can I ask, can you get 0.25 of Polidocanol or 0.1 of STS? Because certainly from talking to experts that I would have followed, lots of people are actually going to half the strength of what is recommended
Ye-
with results
Yeah,
with both
well, obviously
solutions.
there's no 0.2 STS anymore, but there is 0.25 Polidocanol, but it's not it's licensed in the UK, but not currently marketed. But I am pressing Chrysler to try and do that because attending European meetings in the last 5 years, there is clearly a tendency for people to go to a lower concentration sclerosant, which is effective and potentially reduces some of the adverse events, which we'll talk about later. So yes, there is the potential to get 0.25 Polidocanol, which isn't currently available in the UK, but it's used a lot in Europe.
I suppose, though, Richard, if we think that the 0.25 ethoxysclerol is the best sclerosant for that particular patient, we're quite within our rights as doctors or prescribing
Yes,
nurses
to dilute it.
yes,
Yeah,
and there
because
would be no criticism if the patient
no,
had a adverse outcome from using a liquid. Certainly,
because
anyway,
there is nothing commercially available. Wouldn't have been at the time to do
at
that.
this
Yeah,
time.
yeah,
So I think we would say that STS and polidocanol are both good sclerosants to use for microsclerotherapy. There is a difference in strength on a percentage basis. So STS is 2 to 3 times stronger than polidocanol in percentage terms, and roughly 0.2% STS is equivalent to 0.5% polidocanol. But if we feel that 0.1% STS or 0.25% polidocanol is appropriate, then we can make the dilution. Do you want to comment about foam at this stage, or shall we discuss that a bit later, Richard, when we come to that slide? I think we'll discuss that later. Yeah. Okay. In fact, it's the next slide. Richard, you did a very detailed analysis of the literature looking at foam versus liquid sclerotherapy for telangiectasia, and you presented it to the Venous Forum recently. And I've taken one of the slides that you gave me on this matter. Do you want to tell us a little bit about the evidence regarding foam versus liquid and what you think we as clinicians should be aware of when we're making our decisions?
So the evidence is, I was quite surprised, was relatively limited. But then perhaps I shouldn't be surprised because there are lots of things, especially in the venous wall, that are relatively limited in terms of what people do. I first went, and this is the sort of where I started with it, was go to Cochrane Review because they are a good basis to start, because there are Cochrane reviews on not everything but on a wide range of topics and clinical questions, and they will look at the best available evidence that was around at the time, and that's done with a peer-reviewed protocol to begin with, so the actual review process is pretty robust. I've done many Cochrane reviews myself in the past, and they're not straightforward things to do. They're quite involved processes. So this Cochrane review was not specifically looking at liquid versus foam, but it was an overarching review on many aspects of the treatment of telangiectasias with sclerotherapy, and sclerotherapy and laser, in fact. And I, if you're looking at a Cochrane review or any systematic review with a meta-analysis that this particular slide is illustrating, that it's a good place to start, because the reviews are quite wordy and take a lot of wading through to get to the bits you want the information for. But if you can find the forest plots, which is what these sort of charts are, they're a good place to start. So when you see one of these, you don't need to worry too much about the numbers, but you can if you want. But you want to look at the title of what it is comparing. So in this particular instance, it's looking at foam versus liquid sclerotherapy, and the outcome that they're looking at here is improvement of the telangiectasias using polidocanol 0.25%. Interestingly, is what we were just saying. this was the only comparison of liquid versus foam. There were none for other agents in the review, but some of the key things to look for are, first of all, where I've circled in red there is the heterogeneity, because that looks at the heterogeneity amongst the study samples that have been looked at. So if it's a low number, and that's 0, which is good, it means it's got very little heterogeneity, whereas if it's a large number, the heterogeneity is greater within the studies that have been included. And then the next bit to look at is the line that goes down the middle of the chart on the right-hand side. Now that could be indicating many things. In this instance, it's the mean differences between the groups, but it could be a risk ratio or an odds ratio. And along that line will be like a visual summary of the results from the studies. So the first one is actually quite a small study with only about 40 patients in it, and that's sort of indicated by the length of the line, because the line is quite long, so that means it's a small study. You've got less, the confidence intervals are quite a lot larger, but the summary of the data is indicated in the treatment effect in the green dot in there. The next study by Kern, which is a larger study, has a shorter line, so the confidence intervals are smaller, and the summary means are within the green dot. And then the next one to look at is a larger diamond, usually at the bottom, which is a summary of the overall all of the studies added together. Now, very simply, if you want to see whether it's effective or not, or whether one thing's better than the other, all you need to do is look at that big diamond. If that diamond crosses the center line in any way, it means there's no difference between the two groups. If it lies to one side or the other, then it favors whichever intervention it says on the chart at the bottom. And that's the crux of really reading a forest plot, and it's a very quick visual way of seeing what the results mean. So in this instance, the large diamond almost sits in the middle of that center line, and if you look at the numbers in bold to the left of that, you can see that the confidence intervals go from a minus number to a plus number. So that means they're quite wide, and they don't favor one treatment over the other. So in terms of the results from, albeit only 116 patients, means that there was no difference in efficacy between foam and liquid sclerotherapy used in those particular studies. Does that make sense? I've tried to
Yes.
do it quite concisely. We haven't included in here, but it went further in the document. There was another meta-analysis done looking at pigmentation, and again there was no difference between foam and liquid in terms of pigmentation. There was a difference, however, in terms of telangiectatic matting, and matting was more prevalent using foam than it was using liquid.
Oh dear. Zola's not going to like hearing that. Well, it's interesting, isn't it, Richard, when you look at the evidence in the literature, albeit there isn't a huge amount of evidence, the evidence doesn't suggest very much difference apart from matting, which is more common with foam. And that seems to be at odds with the response from people who use foam. They all seem universally to say, wow, this is great.
Can I
Goes to
ask a
show.
question?
Of course. We may not know the answer, but you can ask.
I sort of see that these studies are back, it's sort of one's 1999 and one's 2004. And as I sort of mentioned before, I did flip to start using Polidocanol. And actually, the one thing that I noticed when I was using Polidocanol and trying to foam it using my version of the Tessari technique is it doesn't, or in my hands, it doesn't foam well. And actually, the only time that I managed to get it to foam adequately is in more modern times, when
Viricio.
there've been various, machinery like Viricio. Since Viricio has come in, yes, I can create foam with 0.25 Polidocanol. But actually beforehand, be it using a microfilter or the three-way tap technique, actually I just found that it didn't seem to foam. So I sort of find it's surprising that sort of back a long time ago, either there's some skill that we've lost in time, but how were they producing what I would describe as foam?
They were done with the Tessari technique, but I think I suspect it's one of the drivers for Enrique Roche developing his Viricio devices that Polidocanol in the lower strengths traditionally didn't foam all that brilliantly, using the standard techniques, because it's a different type of detergent to STS, and so STS foams in the most dilute solutions very readily generally.
Well, what do you think, Emma? You're probably pleased just sticking with liquid.
I am, and I think that obviously the study is encouraging, but I think also patient selection is also really important. And I guess that perhaps, I don't know how involved, that was involved in the study, because I think that skin quality, patient selection, medical history, all of those things, I think they're probably more of a driver for obviously resolution and complications.
Hmm.
If you're
Yes, I mean,
using the
I
wrong
don't.
product, you're going to probably get more complications or no results, or
Yes,
the wrong results.
yes. No, I think it. Unfortunately, I have no personal experience of Viricio or using foam for these small vessels. It certainly looks very impressive when you see the videos of the clearance of these vessels, and I think that's the thing that is very striking. Whether that translates into better outcomes, we don't know. And I know Enrique Roche is doing a lot of work on this, and perhaps we'll have that information later when more research is done and more results are available. But given that STS does foam well using the Tessari method, and given that it can be diluted down, I wonder if I'm surprised we don't have any more data to say that foam is better. Is there any suggestion, Richard, from your meta-analysis from the Cochrane review that neurological complications are more common with foam for small vessels?
No, there was no suggestion of that in the review, because unfortunately, that's one of the issues with many studies, is that they either don't report adverse events at all, or they selectively report adverse events, or generally most interventional studies are not powered high enough to detect adverse events because of the rarity of them. That's why we did a post-authorization safety study for STS, because that included 8,500 patients, and then you start to get a better idea of what the true incidence of adverse events is.
Yes. And I know Hugh Davis is going to be presenting at the BAS annual
Yes.
conference in May, so we may have some more information there. Well, that's great. Thank you very much, Richard. So the jury's out on foam versus liquid. Doesn't seem to be much difference at present.
I mean, it definitely works, but does it work any better? I don't think we know the answer to that yet.
No. And we get more matting.
So they
With
say.
reference to the matting, with reference to the matting, because I mean, one thing I've noticed, if I'm trying to use foam at low strengths for telangiectasia, your first injection is fine, but then you get what I describe as a terminal dribble of foam there afterwards, and you're almost always trying to clean your needle because the foam is dribbling out, and that's actually partially obscuring your puncture view. So I'm sure from one perspective, if you use liquid, you inject and then you get a clear shot at where you're trying to inject the next time. But with foam, I'm sure because you've got this partial obscured view, you're actually getting slightly more extravasation than you ordinarily would. And a lot of the time, I'm just wondering, as when Richard said, oh, there's an increased amount of matting, I wonder, is that increased matting in relationship to the fact that actually trying to inject with foam is harder because the foam actually does obscure your needle tip?
Try changing your needle.
No, I'll have to do that.
Because you'll have the air in the needle. You'll have a little airlock when you change the needle, which will stop the dribbling.
So for every single so you inject and then you're going to have to change them. You're going to go through a lot of needles in a day.
Well, what do you want, needles or terminal dribbling?
Stick with liquid and actually see the vessel.
How bad is your dribbling? How bad is your dribbling? I think stick with liquid. Okay, well, I think
it's also just worth pointing out as well that the reason why the lower strengths were never licensed for use with foam is just because there was and there still is really no sufficient evidence on the safety profile compared to the higher strengths in the bigger veins, so that you could not try and license it on the basis of what's available at the moment without doing a very large scale study to show that the safety and efficacy is equivalent.
Yeah. Well, I think we've covered this. I mean, I should have put this slide up a little bit earlier, but this is the main controversy, isn't it? I mean, liquid is currently preferred by the majority of people for telangiectasia. It's licensed for that use, and if you want to stay within the licensing system, you've got a licensed product to do that. Potential advantages are that it's got higher contact time for foam. It displaces the blood. It might be more efficient. I thought maybe there was an increased risk of visual disturbance, but you've corrected me there, Richard, so I'll remove that. I think there are advocates for both sides. Currently, it is the gold standard. It's licensed, and I think there's no pressing evidence to change to foam at the moment. I think that's a reasonable situation. If people want to foam, I don't have an objection. But if you don't have a Varixio machine, or if you don't currently foam, there's no reason to change, I don't think.
I think
Would
for
that
some of
sound
the
fair?
for some of the larger reticular veins, I can certainly see it's going to be potentially beneficial in those situations, and that may be if the reticular veins are not adequately treated, may be a reason for the less successful treatment of the spider veins that are feeding from that reticular vein.
Yeah, that's fair. Fair comment. Yeah. Okay, let's move on to the next slide. Compression after stockings. Compression stockings after treatment. Emma, do you prescribe stockings after treatment for leg spider veins and reticular veins?
No. I think
Zola, do you? Oh,
for
sorry.
us, I've seen more problems with them in terms of how people wear them and sliding down. I've actually seen staining after stockings where they've actually caused hyperpigmentation from the sort of the friction and the trauma. And then, of course, we've got to look at the evidence. So my understanding is there's very little evidence, and I feel like they actually cause more problems.
I agree with that. What about you, Zola?
No, I stopped a number of years ago. I think, I was at a meeting where Kathy persuaded me that there was very little evidence out there for stockings. And then the next big driver was, if there's very little evidence for it, then actually to get a decent, say, RAL Class 2 stocking, it adds to the cost for the patient. And so there was no financial incentive to do it, and there was no evidence to suggest it improved matters.
No, they're expensive and people don't like wearing them. And as Emma pointed out, they do cause problems sometimes. They do rub, they do cause pressure areas, blisters. They fall down. Would you agree with the evidence, Richard? I know you're very well read in these matters, so we always turn to you for the literature review.
Yes, I mean I think the consensus really now is it has no effect on the outcome whatsoever. There are certainly for some of the larger veins, or if you've done extensive treatments, it may help with some of the symptoms afterwards. It there is a suggestion from some older studies that it might reduce pigmentation, but for small veins, I don't really see there's a great benefit for most people.
And prevent thrombus and thrombus formation, and might reduce the need for coagulum release. Talking about coagulum, I mean, one of the questions we got asked to discuss in this session was, how do you prevent the clot within reticular veins particularly? Is there anything we can do to stockings don't seem to prevent them, do they? Zola, do you see people at 2 weeks and needle them?
I don't see people at 2 weeks. I see them normally at 6 weeks. And if it's there at 6 weeks, yeah, I do see people. I will needle and extract at that point areas. I think there is an advantage to release, and I suspect there is an advantage to early release, but actually then just setting up my clinic to get people back at 2 weeks, it's just, it was just too much of a logistical challenge.
What about you, Emma? Do you see people at 2 weeks and needle them?
No, I think I feel that complication is fairly rare. I think obviously is normally self-resolving. So for me, I think that seeing them at 2 weeks again would be tricky from a kind of running the clinics and for the patients, and then generally we'll see them at 6 weeks, by which point we don't normally see that.
So how do we avoid hyperpigmentation after sclerotherapy, and what can we do to reduce it, and how can we treat it once it's established? Any suggestions, Emma?
The starting point for that is that I would tell most patients that they probably will see some hyperpigmentation. And I would normally say something along the lines of, it will probably look better than the vessel did, but there will be some sort of residual staining of some sort. Not in all cases, but I think it's probably quite common as opposed to rare. And we do everything in our sort of power to obviously reduce the risks. When we're looking at the concentrations that we're using, our technique, our patient selection. We actually had a chat about a patient with hemochromatosis, didn't we, a few months ago? And that was actually something that I was really interested in, because I didn't realize that the evidence was that they actually had a much higher risk of staining and hyperpigmentation. So certainly for me, me and the patient made a shared decision not to do the treatment, because we felt that the risks sort of outweighed the benefits. So I do feel that sadly hyperpigmentation is probably one of the most common things that we see. So I think definitely on that thing, we do everything we can to avoid it. But I think counselling the patient that it's probably going to happen is also important.
Okay. Zola, what do you do about, or how do you avoid, what do you think causes it, and how can we minimize it and treat it?
Well, I'm sort of looking at your lovely slide there, and actually I literally concentrate on 1 and 2. I mean, certainly from my perspective, it's a case of, and the same has happened with both agents, both STS and Polidocanol. I think, you use as lower strength as you can. And certainly that seems to reduce things. And the second thing is, let's go back to the discussion about terminal dribble. I think if you're not accessing the vessel correctly, and you're getting extravasation, or you're damaging the vessel, then you will potentially get pigmentation. So I use as much visual aid as I can to make sure that I try and get the needle in the center of the vessel. Or if there is extravasation, then the better view you've got, the quicker you appreciate that things aren't going right and you stop. And certainly from that point of view, then yes, hopefully I will reduce the incidence. But like Emma, I have a series of pictures, and I will just flick people through. And certainly on quite a number of these pictures, you can see brown that has replaced the vessel, and I sort of warn the patient and show them what happened to various other patients over time. It is something that over time reduces down. It's just the patient coming in the room needs to understand a couple of things. One, this is not a quick fix. It will not be one injection. You'll walk off and you'll be on the beach or at the wedding with your short dress 2 weeks later. It takes a while and a course of treatment. And then secondly, it's a case of, you will run the risk of pigmentation or replacing the vein with this brown stain, but rest assured, over time, and it will take time, it will fade and things will improve.
I'm very sorry that Kathy McGuinness wasn't able to join us today because of problems with her internet, but she brought to our attention I think it's called thiamidol, which is a tyranase inhibitor, which seems to help with hyperpigmentation. And she's provided that resource on the British Association of Sclerotherapists website for people who are interested in learning more about it. And again, I'll put the link in the description below. Another colleague has told me about angiogel, which chelates iron in the interstitium and helps remove iron. Just for those who are not aware what causes hyperpigmentation, there are two aspects to it. There's the extravasation of red cells from the blood vessel that's being treated, and the red cells then release hemoglobin and the iron deposits in the interstitium. And then there's the inflammatory process, which leads to melanin production. It's part of the inflammatory process. So you can tackle it by reducing melanin production, which is what thiamidol does. And you can also reduce the iron deposition, which is what angiogel does. I wasn't aware of these two topical agents until very recently. Does anybody have experience of those two?
Well, I was going to also, I know that there are some protocols surrounding dipfenic gel. I don't have any experience with them, but that's certainly in some of our protocols in aesthetics, in our microsclerotherapy complications. And in terms of the actual type of hyperpigmentation that you get, I think if you've got hyperpigmentation or staining that's following the vessel, then that is definitely something that we'll see a lot of. But if you're getting a lot of hyperpigmentation at the actual injection sites, then you probably do want to look at your injection techniques.
Just for clarification, Emma, I didn't quite catch the name of that product that you mentioned.
So dipfenic gel, so Voltarol gel, diphene gel.
Voltarol gel.
You will use it for, I don't know where the evidence is, but it's definitely in some of our protocols, and it's definitely something that I would like to know more about. That said, I do tend to follow the watch and wait approach more often than not, because it generally will self-resolve quite quickly.
I'll tell you what I do, but there's no evidence for it at all. Is I put some Betnovate cream on the treated areas, one dollop at the time of injection before the patient leaves the clinic, and in the expectation that it will reduce post-inflammatory hyperpigmentation. No evidence. Just it seems to relieve some of the symptoms of itch and discomfort and the swelling. Anything that we should be doing, Richard, from the literature point of view in terms of hyperpigmentation? Anything that's...
Well, as Emma has said, injection technique is crucially important, and if there are, especially novices, will often, once they've managed the skill of getting a fine needle into a vein, and try and reproduce those glorious YouTube videos with lots of displacement from this big network of veins, without realizing that one, the sclerosant will be deactivated once it's got a certain distance away, but two, continuing to inject at the same site, you're going to increase the concentration of sclerosant in that site, which could contribute to the pigmentation. But additionally, as Zola's mentioned before, just moving down to a lower concentration, that does seem to be one of the the key things that those very experienced in doing a lot of sclerotherapy would say is a big help. It's not, you're never going to eradicate it, but lower concentrations of sclerosant and a good technique are probably the two keys in that instance.
Well, we need to perhaps speed up a little bit because I've got so many slides here. I didn't realize we were going to talk quite so much. But Zola's very kindly provided these photographs showing pigmentation, hyperpigmentation, which persists at 5 months. And presumably you have a wait and watch policy, Zola, in the
Yeah, I had a wait.
expectation that's going to get better.
Yeah. I mean, I think certainly from the 2 month to the 5 month already, you can sort of see that it is less prominent. So
Yeah.
reassuringly over a relatively short time period. But again, I think one of the errors there was I was using 0.5% Polidocanol. I should have reduced that.
Right. This is the poster that Kathy has provided us with, thiamidol, which is a tyrosine inhibitor. Unfortunately, she's not here to be able to give us more information about that, but that's available on the BAS website if people want to download that. And it is available without prescription from all good retailers. And it's uracil.
We are obviously using that in aesthetic medicine for pigmentation, so it makes sense for sclerotherapy. Yeah.
Yeah. Okay. And the other one is Angiogel. This was somebody on social media who shared her experience, a very experienced phlebologist in Spain, who was telling me that Angiogel removes the iron from the interstitium. Again, I haven't done a literature search, but anecdotally, that is another product that can be used to remove brown marks. Telangiectatic matting, very annoying. It's the appearance of very fine vessels at the site of injection or near treatment sites. Risk factors seem to be high concentration, history of estrogen and obesity. I don't think there's any effective management for this other than observation, and it usually resolves spontaneously in 6 to 12 months. Does anyone have experience of telangiectatic matting and how to deal with it?
I think slow injection technique is important for avoiding it or helping to avoid it.
Yeah. And avoid foam.
Yeah. It's fairly uncommon, I would say, in microsclerotherapy, the types, especially in liquid. We're not seeing a lot of it.
There was a study done by Kourosh Parzi's group in Australia, and they looked at risk factors for telangiectatic matting, and actually identified that people who had bleeding tendencies, so they're not formal coagulopathies of any kind, but people who suffered regular nosebleeds or um, bruised easily. It's often people who are redheads who don't have any formal bleeding issues, but they're known to bleed. I know from my previous life, taking out wisdom teeth on redheads, you knew they were going to bleed for a long time afterwards. And also people who have hypersensitivity type disorders, so asthma and multiple allergies, for whatever reason, seem to be at much higher risk of getting matting than others. The reasons for that we don't know, but that's one observation.
Interesting. Right. Thank you. Well, here's my matting. Matting, if you do get it, you don't forget it because people are very distressed by it. This is actually not somebody I treated just for spider veins. I treated varicose veins and spider veins, and this patient got an area of matting here. Very good result from the sclerotherapy, but the matting was the thing that was observed at 6 months. Fortunately, it went away at 1 year, so she was very pleased and I was very pleased. Most complications are minor. We don't see things like scabs and ulcers very often, but when they do happen, we remember them. And Emma and Zola have kindly well, Emma and Alistair Lewis. Alistair Lewis is the chairman of the BAS. He's not here with us today, but Alistair and Lewis have very kindly shared photographs of their cases. Alistair warns us that we should be very careful when we're treating small spider veins on the anterior shin area. And his advice is possibly not to treat these areas without a lot of information from the patient and a lot of counselling. But these are two ulcers that he had. Fortunately, they did heal very quickly and resolved, but that's his lesson. Beware fine vessels on the shin. And Emma, you shared this series of photographs very kindly. I have to say, it looks horrific, the first one. Tell us a bit about it.
So the patient ignored it for 6 weeks. So that was at 6 weeks when she contacted the clinic. There might have been a reason, like if she contacted the clinic sooner, some green needle extraction, because I don't really, obviously up till this point, she'd just been discharged with her aftercare to sort of see at 6 weeks. I think the big thing here was that the patient had not informed us that she was on steroids, prednisolone. I think the combination of that and her age, she was 73 or something like that, has made me a little bit wary of treating certain age groups, because if the capacity or the sort of like problem with something like this, if it does occur, then healing it is going to be a lot slower. Now, interesting with this patient was she was having other aesthetic treatments. So she'd had 2 or 3 consultations in regards to other treatments, and she'd not once declared that she was taking steroids for a chronic illness, and she hadn't declared the chronic illness. So she hadn't been fully open with her medical history. So I think a combination of age and medical history sort of contributed from that perspective. Then the patient delaying contacting the clinic, that didn't help. And the patient wasn't geographically located close by, so it was a difficult one to manage. So you can see there's a lot of screenshots there because we were managing it very much remotely. It did heal. The third photo is at about 8 to 12 weeks. And it just healed quite simply. We just used Inidine dressings and just took our time with it. We did communicate with the GP as well, which was also very helpful. And we just had to sort of just wait for things to sort of heal through time. But obviously it does cause distress to the patient. But I think often it can be more distressful for the practitioner.
Were you aware of any issues at the time of injection?
No. And I've looked at the immediately after photos of the patient. Sorry, I could have shared them actually. But the actual after photos looked as it should do. There was no obvious sort of area that like histamine response, over injection, anything like that. Everything looked fine.
What did you inject with?
That stage, that was many years ago. So it was Fibrovein 0.2%.
And the lesson we should take away from it?
I think if the patient's not to declare their medical history, that's not helpful. I suppose I don't want to have any ageism, but I think I would just be slightly more mindful of sort of age-related sort of factors, if you like. Maybe the location didn't help as well on the sort of the inner part there, that the way it healed, it was a challenging one to heal because obviously the clothes that she was wearing, that was constantly exposed to sort of friction. So maybe that didn't help in that kind of 6-week period. And perhaps, as I say, with patients now, one of the big learning points to me is about their aftercare. Anything strange or exciting, they must contact the clinic. They must not ignore anything because it's just easier to be involved from the start as opposed to sort of 6 weeks later when things have already developed.
Any observations, Zola?
Yeah, no, I think, as was said, it's the sooner you could have got to that, potentially the sooner you could have helped speed up the healing of it. But it is a difficult one sometimes. You know, as I said, with my migraine patients, sometimes despite asking somebody directly, you will not get information imparted to you.
Anything
We
to
have
add, Richard?
started sending medical information forms out electronically only the last few months, so they can fill that out at home before they come into clinic. And I've been quite surprised by sudden revelations of medical history in
Yeah,
some of our long-standing patients who have never mentioned things. We're having those conversations in clinic all the time, but perhaps now we're asking them to fill it out at home. Maybe they're being prodded to make sure they fill it out accurately.
yeah,
Anything to say, Richard?
No, I mean, other than it's a known complication. The etiology is sometimes difficult to pin down. In this case, it probably is related to steroids. It can be related to an arteriovenous capillary shunt in the skin where you've, in all innocence, injected into a venule which is going straight into an arteriole, supplying the skin, causing it to infarct. Recognizing it earlier, treating it as rapidly is, although conservatively, is the best thing. But it's a known issue, and I think everyone has to be warned that that's a potential complication.
Do you know, I find the medial knee very, very difficult. Very difficult. It doesn't seem to respond in the same way that other parts of the leg do. And I've had a tendency to dissuade people from having telangiectasias treated on the medial knee. Most people sit with their legs or stand with their legs together, and it's not although it may bother the patient more, it doesn't really get seen by observers. So I tend to try and avoid injecting the medial knee. It seems to be resistant to sclerotherapy. I don't know if that's something that other people have found, but that's been my experience. I avoid injecting the medial knee if I can. And I warn them the results are often disappointing. But I haven't, fortunately, Emma, I haven't seen this complication. I think it's just a rare complication. It doesn't seem to be anything you've done incorrectly. I'm sorry that you experienced that. Maybe the age and the concealed medical history contributed. This is one that Kathy sent. Again, she's not here to talk about it, but interestingly, you were talking about veno-arteriolar venospasm, or a shunt there, Richard. I was with Kathy when she injected this area, and the injection proceeded extremely normally. There was nothing untoward about it, but immediately after injection, this area of skin went completely white, and we were extremely concerned that there was going to be skin loss. Kathy recognized it straight away. I didn't have time to get my camera out, nor would it be appropriate to take a picture of somebody's leg when the skin had gone completely white. But she massaged the area very vigorously, and it seemed to relieve the venospasm, and she got an area of hyperemia as a result. And although the skin changed color like this, she didn't get any skin loss. But it was very dramatic at the time. And in fact, we were running a course. Kathy was demonstrating an injection with a very low concentration of sclerosant, and we developed veno-arteriolar venospasm. Emma, what size syringe do you use for your injections?
Well, I started with 1 mils, and because I've been doing sclerotherapy, microsclerotherapy 20 years. Obviously, I know there's evidence now for using a 2 mil syringe size, and that's what we're training our delegates with. It's challenging for me because my hands are used to a 1 mil syringe, but I am trying to get used to a 2 mil syringe.
Okay. What do you use, Zola?
Yeah, it's actually a 3 ml syringe that I use. But it said, okay, so I always avoided. Luckily, I think I got caught in a very good course that I could have recommended. It was a Mr. Gazraj who, when I was learning microsclerotherapy, advised me against using 1 ml syringes. So I never used 1 ml, and I always start with it's 2 or 3 ml syringes. Have been what I've been using.
Well, here's a thing that I need to tell you. Many years ago, I used to believe that if you used a 1 ml syringe, you would develop too much pressure, and you would actually cause disruption of the vessel, because the pressure on the piston through a 1 ml syringe would develop enormous pressures. Until, Emma, I saw Kathy McGuinness injecting with a 1 ml syringe. And she uses a 1 ml syringe routinely. She uses her thumb on the piston, her index finger on the piston. She changes the angle and she rotates and pronates her wrist and so forth. Quite extraordinary to watch. But here's the thing, Emma, and I think you actually get more control with a 1 ml syringe.
I think it's easier to see what you're injecting, because when you're looking
Yes.
down the syringe, everything is marked out more clearly.
Yes. And you can actually inject more slowly and lower
Yeah.
volumes over units of time. So I'm in favor now of a 1 ml syringe if it feels more comfortable. The other
Yeah.
thing about it is you get more resistance with a 2 ml syringe, a 5 ml syringe, a 3 ml syringe. So actually the control on the piston is more difficult. And again, it's against everything that's in the printed books and the literature. It tells you you mustn't use a 1 ml syringe. You'll develop too much pressure. You'll disrupt the vessel. It's hard to control. And I think it's not true. What do you? What's your reading of this, Richard? What do you go to lots of
Well,
courses?
we've
What's the
always
stand?
in our information we've always suggested, certainly at the start, to use larger syringes, because Goldman's famous sclerotherapy book highlights the fact that a 1 ml syringe generates almost double the pressure of a 2 or 3 ml syringe because of the diameter of the plunger. And on many courses I go to, they do use 1 ml syringes, but just to make sure that they are aware that you just need to be a little bit more controlled with the injection, so that you don't induce larger pressures. But Mitch Goldman would suggest that high pressure is potentially a contributor to some of the adverse effects that you get. So it's just being cognizant of what you're using. But ultimately, at the end of the day, there's so few variables in sclerotherapy in terms of equipment. You need to use something that works well in your hands.
Yeah, I think that's right. So Emma, I think you're doing the right thing, and
Brilliant.
Zola, I think you're doing the right thing. I think you're both right. If it works, you're both right. But I used to be dogmatic. I used to say, no. You have to have a 3 ml syringe. Oh, do you bend the needle? Emma, do you bend the needle?
I bend the needle. I feel like it's just a natural thing now to help in your angles and helping you sort of slide in at the right depth.
Yep. Zola?
I generally don't bend the needle, but I generally don't bend the needle. But sometimes, sometimes when you just don't seem to be getting what you expect, and occasionally, so what? One in 10, I'll bend if it's not working for me.
Right. Well, this is Kathy. I'm sorry she couldn't be here. She's got a 1 ml syringe. She's bent the needle, and she's getting lovely blanching of the vessel. And I used to do courses with Kathy. It's a joy to watch Kathy injecting, I have to say. And what she'll do at the end of the injection is press on the area. It will help disperse the sclerosant and physically disrupt the endothelium. So massaging the area afterwards is something that she does quite vigorously with a swab. This is another, again, I'm sorry Kathy couldn't join us. In fact, it's probably good that she can't, because I can then embarrass her. I'm not embarrassing her by saying how much I used to enjoy filming her sclerotherapy injections. Here she is. She's bent the needle. She's just injected a reticular vein there, and she's got wonderful blanching. There she is injecting another vein, reticular vein. Lovely blanching. It looks like it's a fast injection, and it looks like it might be under high pressure, but it's not, because it's a 1 ml syringe. It's a long video. Again, I think this rubbing the area with a swab is really quite good. Kathy does it intuitively, but I think once you've disrupted the endothelial cells by physically rubbing it with a swab, you're actually disrupting the endothelium. I used to call it physico-chemical endothelial disruption. Again, I think Kathy would have liked this, but she can't join us because of the internet issues. But she's just getting her, is that finished? No, she's just getting her syringe ready. There she goes. She's identifying a reticular vein, pops it in, and again, the injection looks rapid, but it's not. Actually, what she's got there is a little bit of a bleb. Don't know if you noticed that, but even I say even Kathy, everybody gets blebs from time to time. She got a little bleb. She's moved to a different area, and here she comes in with her needle. Look at that. Isn't that lovely? So, not everybody bends the needle. I think when people begin, certainly on courses, it's a good plan to get them to bend the needle. That's another little bleb, but she moves again very quickly to an adjacent area, slightly a few millimeters away. Now look at this. She twists her finger, twists it around, and she's using her index finger. I've never seen anybody inject like that. Anyway, she's not here for me to embarrass her, so let's go back. Now I have got somebody else showing us a technique. This is Zola showing us how to inject ankle veins. Zola, you use a blue needle straight.
Yeah, that was a 31 gauge needle.
Oh, that's a 31 gauge, is it?
Yeah. Can't remember who the manufacturer was, but that was a 31 gauge needle.
Very good. No, that's very nice. All I would say is that if people are just beginning, they probably ought not to inject around here. It's very close to a neurovascular bundle. So that's a 31 gauge needle, right? I'm sorry, I thought it was a bigger needle.
Yeah.
Very nice demonstration. And have we got time, Zola, to talk about visualization tools?
Yeah, well, I can talk about it quickly. Yeah, I mean certainly from the point of view of getting the right vein. Yes, you can look at somebody, but if they don't necessarily have translucent skin, it's easier to use aids as far as I'm concerned. Certain things that can be used if you're looking for the reticular veins, the feeding reticular veins, things like Veinlite, which is a transilluminator, works well. You can also use near-infrared imaging to look at the reticular veins, or if you have it, high-frequency ultrasound. But as you're also aware, I'm a big advocate of cross-polarization, or using polarized light. This actually helps you see the superficial telangiectasia. So I think certainly if you look at that picture, the top one, they're all the same person, okay? And there's a cluster of telangiectasia. If you look with the eye of faith, you can just about see the feeding reticular vein that you'd be trying to aim for if you were treating this person. But the middle bit is using a Veinlite, which actually is just flooding the area with either yellow or red light. And actually, it's just like shining a torch down a well. All of a sudden, hopefully, and as you can sort of see between the jaws, you can see the feeding reticular vein. And the last is the same patient using a near-infrared device. So near-infrared, it sends near-infrared light into the skin. The issue is, or the thing is, near-infrared is more absorbed by hemoglobin. So the stuff that's reflected back, less near-infrared, gets reflected back from the vessel than the surrounding tissues. It's then got some very clever software and electronic jiggery-pokery, and in real time, it then illuminates an image on the skin as to where it is. Now, the only thing I would say about things like the Veinlite or near-infrared is they tell you where the vessel is. They give you no concept of depth perception, so you don't know how deep this vessel is. So certainly from the point of view of, they are great to tell you where you need to aim for, but actually, if you have high frequency ultrasound, you can see vessels of that size, and also you will see the depth of where they are, so you'll actually see the needle within the vessel. But as with everything, the more information you give, the more you get, the more likely you are to hit the vessel. I think when it comes to cross-polarization, again, I'll just go back to you're injecting tiny vessels. If you get the needle in the vessel and hit with the right concentration, then actually you're likely to get a better result. Now, this is the same leg showing an area of telangiectasia, and the normal non-polarized view is on the left. Cross-polarization just means it's a technique. You have a light source with a polarizer across it. You have a polarizer across your loop, or what's going to your eye, and they're at 90 degrees. And in essence, light that goes from your light source and hits the skin and reflects back doesn't pass through the cross-polarizer. The only thing that can pass through the cross-polarizer is light that has been altered by the deeper structures. So it gives you a clearer view of the vessels below. And from my perspective, it's sort of a case of, it just means that I can be more convinced that my needle tip is in the right place. Or if it's not in the right place, you just get that hint far quicker than if you weren't using cross-polarization. So look, I'm a big advocate of cross-polarization, and I'm a big advocate of adjuncts to see your feeding reticular veins, because certainly my feeling is if you have telangiectasia you need to deal with, you'll get better results from dealing with the feeding reticular veins and getting them occluded first.
Just remind us of the proprietary name of the equipment for cross-polarization.
Cross-polarization, there's the Cirrus headlamp.
The Cirrus headlamp.
Headlamp, yes.
Yes, and our colleague Chris Pittman in the United States is a great advocate of the Cirrus headlamp, isn't he? But you've made a DIY version, which we can tell people about if they're interested. We can put the link in the description below.
Yeah.
Right, that's great. Thank you, Zola. It's very important to talk about the patient journey, what they can expect, what the realistic expectations of outcomes are going to be, and whether we can clear all their veins, whether we're going to give them blemish-free legs, or whether it's going to be an improvement. And we need to talk about how many visits, the costs, and the long-term risks of recurrence and maintenance treatments. Emma, from your point of view, is there anything you want to highlight in terms of the patient journey when you're managing patients?
I think that if you're getting disappointed patients or complaints, then that's where you need to go back to. You need to look back to the patient journey and have a think about what you're saying at your consultations, because this is one of the most important parts, is what you set out at the start.
Yes, I think that's right, isn't it? Absolutely. Well, we can talk about that perhaps on a subsequent masterclass. And our president, Philip Coleridge-Smith, wanted us to show this. This is actually the wrong way round because I've turned it upside down, as it were, but the before is on the right and the after treatment on the left. And this is a patient with Ehlers-Danlos syndrome who had extensive telangiectasia on the lower parts of his leg. And Philip and his team treated this patient with 5 sessions of 0.1% STS, liquid, I presume. Foam wasn't mentioned. And this is this is very impressive, isn't it? I mean, very, very good clearance. Any comments, Zola, on this photograph provided by Philip?
Yeah, it's, I mean, how can I put it? That scalded appearance is something that you normally try and run away from, or
Yeah.
you wouldn't actually, you actually particularly wouldn't want to take on. And in fact, I saw a similar patient, or I saw a similar appearance, once had a long discussion, started treatment, got into about 2 or 3 sessions and wasn't particularly impressed, so I actually passed them on to Alistair. Now, Alistair, I didn't have the pictures, but sort of Alistair sort of is happy that, you know, they've had a further 3 or 4 treatments and there is a noticeable effect. But I think it's a case of, if you have a good technique, know what you're doing, but it also, as you say, this is 5 sessions, you know, so from the point of view of, you know, sort of the patient has to know it's going to take multiple treatments to get a noticeable effect. And that is a noticeable effect because you still see areas on both feet where you can still see redness. But as you say, it is significantly improved to how it was before.
Any comments, Emma?
Again, I would agree with Zola. I would have run away from that type of patient.
Yeah.
Certainly in my practice, far too complex for the types of things that we're doing. But it's wonderful that there are experts out there that, you know, it can sometimes, I think sometimes you do need the other end of the industry to kind of dive in for these types of patients, because that is a phenomenal result. So,
Fantastic result. Fantastic.
yeah.
I mean, I take my hat off to Philip and his team for doing this and getting
Yeah.
that great outcome. Though, as Richard has pointed out, don't their teeth fall out as well, Richard?
Yeah, collagen defects. Yes, it's a collagen defect, so they tend to get early onset gum disease, and then they lose their teeth early as well.
Hmm.
I think Philip
Well,
is like the Star Trek of phlebology. He boldly goes where no other man would dare go before.
I love that. Yeah, absolutely.
And when
he's the
Philip
Captain
stops
Kirk.
treating veins, who is going to treat the veins that no one else wants to touch?
Well, that's another topic altogether. But I have to congratulate Philip and his team for an excellent result. I would have turned that patient away. I wouldn't have embarked on that. And I think the 3 of us would have referred that patient to Philip. Maybe that's where Philip got this patient. Maybe it was somebody who referred him to this referred him this patient. But anyway, congratulations, Philip. Resistant veins. Is there anything we can do for resistant veins? You know, when you do 2 treatments and you don't see much effect, do we stop? Do we say to the patient, look, microsclerotherapy is not for you? Or do we scratch our heads and go to plan B? What would you do, at Zola, for resistant veins?
Normally, I would have a very close look around with ultrasound and see if there's something feeding that has been missed or wasn't obviously apparent. But I'd sort of have a strong hunt around, and then personally, if it's resistant and I think I should have got a result from this point on, I would actually just pass these patients on to Mr. Lewis, to Alistair Lewis, because I sort of, as a general rule, yeah, if they're not progressing in the time frame that I expect them to progress, or they're not getting the effect that they get, and then I can't see a feeding reticular vein, then I just hold my hands up and I pass them on to a colleague.
Right.
So
What
I've
would
done
you
this on a
do,
couple of
Emma?
occasions.
Resistant veins. Refer them. Emma?
I think exactly what Zola said. I think, though, just coming at the other end, if maybe you feel that maybe you'd rely on maybe a little bit more expert advice because you're just at the start of your microsclerotherapy journey, then just communicate with sort of maybe expert peers first and just see if there's anything that you could change. Maybe look at the, the product that you're using, the concentration, definitely obviously underlying pathology, but maybe just a conversation first as well with maybe someone who's a bit more experienced than you, just to see if there's anything you could change. But I think certainly for me, very experienced, I've probably ticked all those boxes. I'd be looking at referral pathways.
Have either of you tried injecting saline into the area or tumescence? Tumescence
No.
assisted? No. Any comments, Richard?
Not too much compare in addition to what they've said. I mean, I think sometimes some veins, if they're very long standing, they will have all their any elastic tissue that was in them is probably now subsequently scarred up, and those might be the ones that just won't be treated very successfully with this technique.
Okay.
And if they're slightly larger, then you maybe go for the total EVLT technique that we're going to hear about at the BAS.
Yes. Well, I think we would refer those to Philip Kelleher-Smith.
Yes.
How can I read? So this is a group of questions we got from various sources, replies to the new BAS newsletter, comments on Instagram and comments on LinkedIn. How can I reduce thrombus in reticular veins? This is a comment from somebody who was saying, whatever I seem to do, the reticular veins go black, and it's very annoying for both me and the patient. What can I do?
It's a really tricky one without seeing what their technique is, what their choice of product is to answer.
Yes.
Because I think I'd need to see all those things first before I make a decision if there's any training needs before kind of commenting. Because I think if you're getting them in every patient, then I'd probably be looking back at like what the technique is and what the product choice is, etc.
Yeah. Okay. Any comments, Zola?
No, again, I think it's, from the point of view of you, as a general rule, I would inject and I'll then put stretch or pressure on for a while. But from the point of view of it's something that I see, but I wouldn't see time and time again. It's not a frequent thing, but it is a thing I see it sometimes. So yes, question is exactly what is happening technique wise to get this repeated result.
What should I do with patients on tamoxifen?
Yeah, me. For microsclerotherapy, I find it slightly difficult, but I will have the conversation. I mean, certainly from the point of view of VTE risk factors, as far as my understanding is, tamoxifen is actually worse than just oral estrogen. So from the point of view of my varicose vein practice, then certainly I would give appropriate prophylaxis to the patients. I mean, certainly if they're on tamoxifen, they're on it for a reason. And from that point of view, as a general rule, the reason they're on it outweighs the cosmetic treatment of these of the veins. If I'm using microsclerotherapy, I would have the conversation with the patient, because certainly from the point of view of, for microsclero, I think, although there is a DVT risk, it's not nowhere near as high as the DVT risk for if you were doing, say, foam sclerotherapy on patients. So I would make people aware, I would have a conversation, and I would give consideration if the patient was very concerned to prophylaxis. I wouldn't suggest stopping tamoxifen.
Agree. I think it's definitely a very compelling relative contraindication. So I think you really have to look at every patient individually. I come in from do we need to do this approach? And how much are these aesthetic vessels bothering them? So I think it's a relative contraindication and probably come to a different answer with every patient. But majority of patients, I would say, let's take the starting point that, is giving you additional risks.
Richard?
I think everything that's been said so far I would agree with. We don't know genuinely the risk with microsclerotherapy and tamoxifen, but the
Yeah.
VTE risk is high, and I think you'd have to look at other VTE risks as well, and make sure that the patient was very well aware, and also that they were very good at adhering to a good exercise protocol afterwards, that they were moving, and just perhaps do a lesser treatment perhaps than you would with other people, and do it in smaller doses. But certainly, it's a discussion that you'd have to have, it's a risk-based approach, I would say, for that.
Well, I'm very risk averse, so I'd probably say no, but that's just me. I don't like treating people on tamoxifen, but I think probably Zola and Emma, your approach is very sensible. I'm just a scaredy cat. How do we ensure the needle is in the vessel without aspiration? This is a gentleman who's asking us about spider veins and reticular veins. Can we be sure the needle is in the vessel without aspirating?
Well, with reticular veins, depends what you're using. If you've got high frequency ultrasound, then yes, you can, because you see it entering, and you can flush and just ensure that you are in the vessel. You can use adjuncts to go in, but it's certainly a case of the proof is in what happens when you start slowly injecting. And certainly if you've got good visualization onto the vessel that you're injecting into, and it follows the pattern and the course that you're expecting, that's fair enough. But if you suddenly see that it's not following the pattern that you're expecting, then you're probably getting extravasation, and that's time to stop.
What would you do, Emma?
I don't actually aspirate. I sometimes do, but I think I just rely on, as you become more expert, you just get a feel. You just know. It's just like a simple thing that it's hard to teach, but you just know by it's almost the friction of the needle.
That's your 1 ml syringe, you see.
Yes. Yeah.
I'm struggling to get 0.2% fibre vein. What should I do? Well, if you're Zola, you get 1% and you dilute it down. But what should they really do, Richard?
Well, we can say that there has been no 0.2 fibre vein for well over a year. It hasn't been manufactured for well over a year now. The recommendation would be that you would use etoxysclerol 0.5% or 0.25% when it becomes available, which is available currently through Cora Healthcare, and they distribute it through 3 wholesalers: Alliance Healthcare, Health Exchange, and Wigmore Pharmacy, and that's where you get those drugs from. But if they're truly not available, then yes, you could dilute fibre vein, but very carefully, and you would probably contact an expert or contact us for details of how to dilute carefully.
Is compression necessary? Well, I think we've covered that. No, it's not. This is a great question from Eduardo Juarez from LinkedIn. I'll let you read that. But he's basically saying, what do we think is the most influential aspect of development of hyperpigmentation? We've covered that. How do you prevent hyperpigmentation? We've covered that. Do you use compression post-treatment? We've covered that. Are there any complementary methods? Well, we don't think so. Emma uses diclofenac. I put Betnevate cream on. We avoid... Oh, do you stop iron tablets? Do you stop people who are taking iron supplements?
I don't know.
No? Should we,
I'm
Richard?
interested to hear if we should.
Yeah, Richard. The thing about, we always turn, all of us on this panel, we always turn to Richard.
That's right.
Richard knows the literature better than anybody else I know. Over the years, I have emailed Richard constantly saying, have you got a paper on such and such, or could you provide me with the latest information on such and such? I'm sorry to embarrass you, Richard, but you really are the person we go to when we want to know what the literature is. So should we be stopping iron supplements, Richard?
Well, I don't know that there's any evidence on that specifically, but there is a suggestion from some of the studies that in people with iron storage diseases,
Yeah.
hemochromatosis and so on, that there is a greater risk of pigmentation. Again, you'd have to. I don't think we've got a definitive answer
No, we haven't
for
got
that. And it's maybe more important they're taking their iron than risking a limited period of pigmentation.
Yeah, I think so. And perhaps some of these creams that Kathy's brought our attention to may help. The thiamidol and possibly the iron chelating agent. But no, there's nothing much we can do about this. I'm sorry to say, Eduardo, we're not much help to you. There isn't enough evidence. Well, I think I prepared these slides in advance when I was hoping to have Kathy and Gaynor join us, but I wanted to thank the faculty for giving up their time. We've been online for nearly 2 hours. I must thank you all for your perseverance and stamina and putting up with my comments and questions. It's very kind of you to give up your time. If anybody watches this for 2 hours, they have our admiration, and we hope that this has been a benefit to anyone. So, Emma, thank you so much for giving your perspective and giving up your time. Zola, thank you for contributing. Richard, wonderful to see you again. I hope to see you all again soon. Thank you very much. Now, if you found this podcast useful, do please leave a comment in the description below. Also, please consider subscribing. That way, you'll be the first to find out about upcoming events, resources, and educational material. Thank you for watching.